Hello and welcome to today's webinar. My name is Stephanie and I'm with the company behind the Navilas laser system. And I'm very happy to welcome today Dr. Per Heuvels from the network of practices of Augenärzte Niederelbe. So welcome, Dr. Heuvels.
Thank you for the invitation.
Today, we're going to do a little different format. We are going to go through some slides and case examples and have a short conversation on how navigated focal and peripheral laser therapy is integrated into daily practice workflow. So I'm looking forward to that. Before we start, maybe just a few words about you, Dr. Heuvels. You studied medicine in Göttingen and achieved your promotion with Professor Neuhan at the Technical University in Munich. And you did your fellowship in Rostock and also worked as senior doctor for anterior segment surgery. So can you maybe say a few words? Why did you then decide to have your own practice in ophthalmology?
I started my business in 2017 because I found myself in the situation that I couldn't make the decisions I wanted to make anymore in a clinical setting. I am a practitioner, and so I wasn't very keen on studies anymore, and I wanted to treat patients. And in the modern way of ophthalmology, this is very streamlined and not very broad anymore. The conservative eye treatment is not part of the everyday life of a general practitioner anymore. So since I have the great fortune of having a wife in the same field, we decided to set up our own company and do what we think is best for the patient.
I think you now have 4 locations and you obviously are very welcome by the patients in the services you offer. So when we look at the requirements you had for a laser platform, can you maybe pick 1 or 2 of the most important points on this slide?
Well, when we started off in a conservative practice from the 70s, 80s of the last century. So there was no laser platform in the beginning. Since we started off and had another 20, 30 years ahead of us, we went for the modern platform. And the machine had to cover all areas of laser treatment. But it's not a slit lamp. You can feed in different modalities of diagnostic reports and plan your treatment. And having done a lot of laser therapy in the clinic, knowing that patients suffer from this treatment quite severely in terms of the bright light and the contact lens and the repeated appointments necessary to get the laser therapy done. All this was, in my opinion, solved by this platform.
Here we see the setting of a typical treatment. Maybe that's a good transition to look at some cases. This is the first one, typical PDR case. Maybe you can briefly repeat how you approach such a treatment, which are the challenges, and maybe comment on the parameters you use.
For this case, obviously, we need the periphery to be coagulated. And even here, you have 2 options. You can either work contactless or with the standard 165 PRP, which I like very much. And basically, then the knowledge of laser retinal therapy comes from the last century. You have 3 parameters. You have the spot size, you have the exposure time, and the energy, and this makes a burn. And the nice thing here is that you can draw your pattern. You're not limited to prefixed hexagons or squares. So you cover the area you want to treat, and then you use your mouse to free the vessels, and then off you go. In a pan-retinal setting, I normally start nasally and try to finish a third of the clock. And then I give the patient a new appointment. What we also know from a very long time is that if you have fixed settings of the 3 modalities I mentioned, time, spot size, and energy, the intensity of the burn will differ from the posterior pole to the periphery. So what I tend to do is use two areas. As you can see here, I start with this more central one with a higher energy to get a nice burn. And when it comes to the periphery, I just go 2 or 3 clicks down, let's say 20 to 50 milliwatts down, and then have the same intensity of the burn in the periphery. This is a picture of the same patient after panretinal treatment. And this is just to work out that you can see the proliferations are starting to vanish, especially at the optic disc. And this is just to show that even with a lot of small burns, you can control a proliferation.
Thank you. I mean, here we just have a picture after another patient, another treatment. What I especially like is on that you see a really evenly spaced pattern. Any comments here?
No human can do that. The idea of the treatment coming out of this machine is from the last century, but it is paired with the exceptional advantage that a computer software is watching you, and that the eye tracking and the software will ensure that you get these sort of patterns. And obviously with a patient moving and blinking, cannot distribute such burns that evenly without the help of a machine.
So next case is a retinal vein occlusion. Same systematic approach of pre-planning. Do you want to further comment on that one?
When you remember the last pictures, this is taken with the non-contact panretinal lenses. So actually here there's no contact lens on the patient, and you can go quite far into the periphery. You can even tilt the lens a little bit and have the patient look slightly to the side, so that you could finish the case even without any contact to the globe. I have to say, in my everyday practice, I still prefer the contact lens, since it controls the patient a bit better. But it's even that is possible using non-contact in the periphery.
This is a fill-in treatment.
This is, yeah, and it is to show you the difference between non-contact and the 165 PRP. And this is how it looks like when you use the contact lens in the periphery. What we do is, as I said, we divide the retina into thirds, and or even do finish it in 2 and have a third touch-up treatment. And in this so-called fill-in or touch-up, I convert to smaller preset patterns. You can you don't have to draw your spots and then have the machine do it. You can also choose a hexagon or a square and define all the parameters, as in spacing and spot numbers, and then you can move your joystick to the areas where you just need a little bit more and fill in the gaps.
Thank you. I mean, you can also reach the very far periphery, as we can see here. So retinal tears, typical treatment you perform with a laser?
It needed to be able to do this. I didn't want 2 lasers in the practice. So when someone comes with a horseshoe or a lattice or whatever you want to coagulate, this is what we do. Yes, we sit the patient in front of the machine. There is not that much multimodality planning before that. You just shoot a picture of the area and then you draw your belt around it. The rules are the same. You want a confluent burn, let's say 3 to maximum 4 spots in around the hole, so that it's secure.
Thank you. So we have one last case, focal case. So for diabetic macular edema, I think this is where the external diagnostic overlay becomes really important, also to identify the microaneurysms.
Mm-hmm.
So maybe you can explain to us, how do you decide which ones to laser and which ones maybe to spare out, as we can see on the picture, on the plan?
Laser therapy of the very posterior pole with the injection therapy was more or less abundant before this platform came. everyone was talking about injections, but the key is to hunt down the microaneurysms so that you you don't get a reoccurrence. And with navigated therapy, you can hunt down a single aneurysm by overlaying it to the picture and specifically target your burn onto this microaneurysm. What we normally do is in such patients, if they have a clinical significant macular edema, of course, you start injection therapy to reduce the edema, which makes the laser therapy much easier. And as a add-on treatment, then comes the laser treatment, whether it is a hot burn or even this new modern micropulsing. Both works. We obviously spare out the two areas, the optic disc and the fovea. And as you can see here, we have an area where we already have hard exudates. So there's no point in single spotting any aneurysms. So we have like 3 areas of a small grid around the very bad areas, and then we look around them whether we can find some bright aneurysms and then treat them with the focal spot as well.
Yeah, so thank you very much for this nice conversation. Maybe a last comment. How did you manage to get used to the new concept of the laser? How was the learning curve? Are there any tips for colleagues who might be thinking about learning this new technology also?
Well, it's a pricey decision, but it's a good one. And but the thing is, you need to get your hands on, and you have to do it. It's like every other invasive therapy. You have to do it to master it. From the handling, it's very handy that all other diagnostic modalities also switch to this. Look at the screen and move the joystick. And if you can take pictures with a system like that, it's just another step to place the burns. So there is not a very long and flat learning curve. It's pretty fast. What I like about this is nowadays your eyes are so pleased with the wide angle imaging. You get these big pictures of the retina, and when you sit in front of your laser, you're looking into a slit lamp with a very small field of view, and everything is upside down. So this doesn't go together anymore, and this machine works very nicely as you know it from your SLO scanners. You can see what you're looking at on a big screen, and then you can plan, and what you plan is what you get. And this is something I think we should consider doing modern laser retinal therapy.
Thank you. So thank you very much for your time today. We appreciate the insights, the comments, and I wish you a very good day.
Thank you very much.